In February 2025, a federal class action was cleared to proceed in a Minnesota courtroom. The defendant, UnitedHealth Group, the algorithm at the center, NH-Predict, acquired for over $1 billion. Skilled nursing facility denials had surged to 9 times their historical baseline. 90% of those denials were later reversed on appeal. This white paper examines what happens when a decision support tool becomes an automated gatekeeper, one that enforces discharge timelines with a 1% variance target and disciplines clinicians who deviate from its projections. The paper's argument is precise. The transition from black box predictive wrappers to causal, explainable, board-governed AI is no longer a software architecture debate. It is a legal one. NH-Predict was trained on 6 million patient records. From that data, it derived average lengths of stay for post-acute care patients by diagnosis. What the model could not represent were the specific causal factors that make individual patients diverge from the mean: no caregiver at home, a rare blood disorder poorly represented in training data, financial conditions that would prevent outpatient recovery. When care coordinators were disciplined for deviating from the algorithm's projections, the system had crossed from decision support into coercion. The missing element was not more data, it was causation. Deep AI governance for high-stakes clinical decisions requires 4 architectural layers that NH-Predict lacked entirely. The first is causal inference, asking not what historically similar patients did, but what factors drive an individual patient's need, and identifying proxy variables that correlate with protected characteristics while carrying no causal weight. The second is explainability at 2 resolutions: SHAP, S-haply additive explanations, surfaces which features most influence the model's output across the population, giving auditors a systematic view of potential bias. LIME, local interpretable model-agnostic explanations, generates an explanation for a single decision. For a patient with methemoglobinemia, LIME would have flagged that the algorithm was weighting average recovery time while ignoring life-threatening blood oxygen levels. The third layer is confidence scoring, a metric attached to every prediction that routes low-confidence cases to human review before a decision is finalized, not as a fallback, as a designed control. The fourth is the NIST AI risk management framework, structured around 4 board-level functions: govern, map, measure, and manage. The litigation record is the evidence of architectural failure. The Senate Permanent Subcommittee on Investigations found that NH-Predict's post-acute care denial rate rose from a baseline of 8.7 to 10.9% to 22.7%, an increase of 108 to 160%. Of those denied claims, only 0.2% were ever appealed, not because the denials were correct, but because elderly patients lacked the resources to navigate the process. Carol Clemens, recovering from methemoglobinemia, paid $16,768 out of pocket after coverage was terminated. Meanwhile, in January 2025, the FDA issued draft guidance FDA 2024D 4689, a mandatory 7-step credibility framework that NH-Predict failed at every stage. 72% of S&P 500 companies have now disclosed material AI risks in their annual SEC filings. The EU AI Act classifies healthcare AI as high risk, with penalties reaching 7% of global annual turnover. The Lokken ruling pierced the federal preemption shield that Medicare Advantage organizations had historically relied upon to evade state law claims. The lesson for the board is direct. Algorithmic efficiency without governance is litigation waiting to happen. The paper walks through the causal architecture, the XAI mandate, and the NIST governance framework in full technical detail. Read the 11-page brief, approximately 15 minutes of reading time.